This conference will now be recorded.
I will be presenting on the study that we conducted. It is an audiological profile of a cohort of school-aged children with HIV-AIDS attending an antiretroviral clinic in South Africa. I was the primary investigator under the supervision of Dr. L. Joseph and Ms. Parkin. The recent estimates show that approximately 280,000 children between the ages of 0 to 14 years are living with HIV in South Africa. South Africa is currently dealing with the quadruple burden of disease where HIV has ranked the highest. Now, as we are aware, HIV can result in sequelae that affects different parts of the body, and that is inclusive also of the auditory system. And the disease or the virus itself can give rise to a mild conductive hearing loss, mixed hearing loss, sensory neural hearing loss, even central auditory processing deficits. Now, a presence of a hearing loss will definitely impact on the child's ability to develop language normally. And the presence of a hearing loss can result in auditory processing deficits, which will interfere with literacy skills. These skills include the ability to pay attention, auditory analysis, synthesis, and auditory closure, which are skills that are required for reading and writing. Therefore, this has an impact on the overall outcome of these children where, due to poor literacy or a poor scholastic performance, their outcome is compromised because they're also limited in terms of tertiary access to tertiary level of education, and furthermore, future potential of vocational potential is also affected. So therefore, it's imperative for us to identify these children early, not only for them, for their full potential in future, but also for their academic potential to be reached or maximized. Now, currently in South Africa, there is limited research that has been conducted in the pediatric population. Majority of the studies that have been conducted in the adult population. Therefore, it was one of the rationales used for why the study is important. And this information was going to assist the audiologists to basically identify the type of hearing loss, degree of hearing loss, configuration of hearing loss, which will be used alongside with medical intervention to assist or to intervene early to promote a better prognosis. The study, therefore, aimed to determine an audiological profile of a cohort of school-aged children with HIV-AIDS at an antiviral clinic in KZN. This is a province in South Africa. The objective of the study was to describe the occurrence and the nature of hearing loss in terms of type, degree, symmetry, and configuration. The study followed a non-experimental, descriptive exploratory design with non-probability consecutive convenience sampling. The reason for convenience sampling was that the researcher, which is myself at that time, was employed at the site where the children were accessing their antiretrovirals. Now, the description of the participants. We had 30 participants, which were sequentially recruited over a period of 3 months. Their ages ranged between 6 to 12 years, and therefore their mean range was 4.3 years. 60% of the participants were males and 40% were female. All participants were Black. Due to the demographic population of the site, where majority of the participants are Black. And the grades range from grade R to grade 7. Now, 90% of the participants were on ARVs, and one participant was still ARV naive during the testing because his viral load was still at undetectable levels. The study followed the following data collection process. We first obtained ethical clearance from the UKZN Biomedical Research Ethics Committee, and then ethical clearance was obtained from the Provincial Department of Health, then also from the study site itself. And also permission was obtained from the HOD of the clinic to conduct the study. Informed consent was obtained from the caregivers, and the child assent was obtained, as they are able to give assent at that age. The testing followed the following procedure. A case history questionnaire was developed for the purpose of the study. This was then subsequently followed by a medical review where the medical records were reviewed. This is where the information of the viral load, CD4 count, and other medical case history information was obtained, like comorbidities the patient presented with. In terms of the audiological testing itself, the following tests were used. Otoscopic examination, which is to examine the outer ear and the ear canal up to the eardrum. Emittance audiometry to assess the middle ear, and also the stapedial muscle reflex archway. Then we also did pure tone audiometry using both air conduction and bone conduction. This allowed us to get functionally how the patients were able to hear, and the frequency ranges that were used were between 125 hertz right up to 8,000 hertz, which are within the communication ranges. And then we also did speech audiometry, which was divided into two sections. The first section was speech reception threshold, and speech discrimination scores were also obtained. We therefore afterwards did what we call distortion product autoacoustic emissions. This is the test that assesses the outer hair cell function, and it is an objective measure. We also further on added on a neurological ABR, which is the test that is objective, that assesses the neural synchrony of the auditory pathway. Thereafter testing, the caregiver would be given feedback in a language that they would understand. Luckily, the researcher was fluent in both languages, English and isiZulu, which is the main language of the province, to be able to explain the results. Those who had audiological problems were then referred accordingly for management, i.e. They were referred to a speech language therapist if they presented with language difficulties, and they were also referred for ENT management if they needed further otological management and other assessments. And then the participants were provided with a pamphlet just to highlight the importance of hearing healthcare, and for participating they were given incentives, which is a small token of appreciation. Thereafter, the following results were obtained. From the case history interview, we noted that the caregivers reported that the children did present indeed with symptoms such as ear pain, tinnitus, dizziness, recurrent chest infections, which often lead to middle ear infection. 43% of the caregivers reported that they do suspect that the children have a hearing difficulty, but they haven't had any audiological assessments. And then 50% of the caregivers did report middle ear infections, and 80% of the participants did report that they did suspect or present with ear-related difficulties, but they were never referred for an audiological assessment. And then 50% of the caregivers reported that these children are already having academic difficulties, where 50% of them had already repeated a grade, which is an indicator of not coping academically. And then after the case history interview, they underwent the full diagnostic testing. But from the medical review file, this is the percent. We had 4% of the participants ranging in the 25% or over CD4 cell percent range, and 89% were between 12 and 24%, and only 2 participants were under 15%. Now, the audiological results are presented as follows. The otoscopic examination indicated that 57% of the participants did present with a hearing loss, with abnormalities in the outer ear. Those included the presence of wax. They also presented with middle ear pathologies, such as otitis media. Some of them also presented with foreign objects in the ear. Then we went further to do emittance audiometry. Type A, tympanograms, means normal middle ear function. Type B, C and AD indicates that there is the presence of middle ear pathology. We also had about 16% of our participants who we could not test emittances because of the presence of middle ear pathology, such as an active infection or a perforated eardrum. We then went to assess the stapedium reflex, and we noticed that for both ipsilateral and contralateral, some of the participants could not be tested because of the presence of middle ear pathology, but we did have those who presented with normal ipsilateral and contralateral reflexes as presented in the table. Sorry, we're trying to continue. Sorry. Then we went and we did pure tone audiometry. In terms of the pure tone audiometry, we could only test 28 of the participants. They were able to be conditioned for pure tone testing. Other 2 participants could not be tested. From the results, we noted that there were participants who presented with a mild, moderate, severe hearing loss, and then the type of hearing loss, the conductive hearing loss, was the most predominant hearing loss, as indicated in the graphs. We also noted that there were those that presented with the unilateral and bilateral hearing loss, and also the most common configuration was the rising configuration, which is in keeping with conductive hearing loss. We also did speech reception thresholds where we obtained good pure tone SRT PTA correlation indicating good test reliability. We also obtained 7% of the participants had fair reliability, and 11% of the participants also presented with pure reliability. We went there further on to test their speech discrimination scores using a speech discrimination score word list for the pediatric population, and 96% presented with speech discrimination scores above 88%, indicating good speech discrimination abilities. However, we did find 1 participant who had difficulty with speech discrimination scores. We thereafter went and conducted distortion product autoacoustic emissions, where we had 3 participants fail in the right ear and 12 in the left ear, and 12 could not be tested because of the presence of middle ear pathology or wax. And then we also went and we conducted the auditory brainstem results, which is the neurological ABR, and we did find that there were abnormalities. Now, the ABR indicated that participants were starting to show neural dyssynchrony. Almost half of the participants in the study had some degree of hearing loss. However, we noted that the prevalence of 32% reported in literature was our study prevalence of hearing loss was higher than what the literature had reported. However, we do note that due to the sample size, we cannot generalize these findings. And secondly, conductive hearing loss was the most type of hearing loss that was prevalent, and with mild hearing loss also. This does indicate that these children who are immunocompromised are susceptible to conductive hearing loss, which will also impact on their ability to hear and also has impact on their scholastic performance. And then we also noted that sensory hearing loss could have been attributed to meningitis and ototoxicity. Further to note, when the study was conducted, it was during the winter season in South Africa. Hence, we are also assuming that the incidence of hearing loss was higher. The degree of hearing loss varied across participants, but the mild hearing loss was the most prevalent, and it also has been linked with difficulty with scholastic performance. And we also noted that despite caregivers reporting otologic conditions, no referrals were made to the audiologist. We also note that the limitations of the study are as follows. It was a cross-sectional design, It was limited in terms of the sample size, and also our testing was only limited to ABR neurological, which is a high burst tone frequency assessment, and we could not do the audiological ABR due to testing. However, Matas and Parkin recommend that the ABR is a measure of assessing or detecting subtle neurological changes. We do recommend, however, that a larger study should be carried out, not so that the results can be generalized to the public in all. Our conclusion was that a high percentage of children with HIV on ARV treatment who attend an ARV clinic did present with a hearing loss, with the conductive hearing loss, which is mild, being the highest prevalence. This has an impact on language development, which will later on have difficult impact on learning and vocational potential. So therefore, the study is urging that audiologists should be included in the multidisciplinary team for children to monitor children, especially in South Africa, where we have such a high prevalence of HIV. Thank you. I open it up for questions.
Yeah, so if we have any questions, yeah, please, you can now put it up if there are any questions. Yeah, I guess there are no questions. So yeah, thank you for your presentation, Dr. Zandili Peter. It was really informative to know about the hearing loss also included in the HIV. So yeah,
No, thank you
thank
for
you
the
for that.
opportunity.
And I'm sorry.
I was saying thank you for the opportunity to present.
Oh, yeah, thank you. Thanks a lot. So yeah, now understanding the present situation of the COVID-19, Dr. Simon Raymond was unable to attend as he was stuck in some surgery and he will not be able to be presenting now. So we have the e-poster presentation of Dr. Masafumi Seki from Tohoku Medical and Pharmaceutical University of Japan. So I'll be presenting on her behalf. Like she have just sent us the poster presentation to be shared as she is unable to come give a presentation right now. So this topic is about the clinical differences in hospitalized adult influenza patients between the AH1N1 PDM09 and AH3N2 seasons in Japan. So yeah, you can just zoom in and zoom out for your convenience with your buttons present at the right corner. So you can just check with the posters and we can provide you a certain time to just check it upon. And if you feel this is not clear, and yeah, you can just send us an email and we'll provide you the poster physically. Like we'll just mail you the poster if you need it. So yeah, I guess everyone had a look at the other two presentations that I've just displayed. So we do not have the presentations of Dr. Seeman Raiman and Dr. Roberto Mario and Dr. Leodio Mario right now, as they have sent us an email that due to the present pandemic situation and it's an emergency for them to help the COVID patients. So it was not possible for them to join with us today. So with this, we are at the end of the session today. And yeah, if anyone wants to tell like any suggestions to us or any thank you note from our side, yeah, you'll be please welcome to do that.
I just want to say thank you. It was a very informative 2 days. I've learned quite a bit, especially the interesting research that's been conducted in other countries in the different areas. So it was very informative. I just have a question. Will these be also made, the presentations also from yesterday, will they be made available?
Oh yeah, sure. We have already recorded everything. All the presentations are being recorded, and yeah, we'll be uploading it in a link, and we'll send you the link for your reference.
Thank
We'll
you.
do that. In 2 days, we'll send you all the presentations, like all the recorded presentations will be made available online, and we'll help you and we'll provide you the link also.
Thank you.
You're welcome, doctor. So if anyone has any questions, please do let me know so that we'll help you out with that. So yeah, I guess there are no questions or anything. So yeah, we are really thankful for all your patience and your time. And yeah, regarding the participation certificate, we'll be sending it to your email right now, like in maximum in 15 minutes. Everyone's certificate will be provided through email. So you can just check your email in 15 to 20 minutes. That will be done to you. Yeah, so yeah, then that's it. So yes, Dr. Deepak Kumar, yeah, it'll definitely contain the title of talk. Don't worry. With your presentation, yeah, it'll the title that you've presented, yes, you will have the presentation title in the certificate.
Thank you very much, ma'am.
Thank you. So yeah, if there's anything needed, you can also contact us through email. And I understand the present situation of the pandemic, and that was the main reason that we have been organizing online. But yeah, once everything will settle down, and yeah, we'll definitely meet up or catch up in an offline conference present physically. And yeah, we'll definitely make time for that, and yeah, we'll do that for you, and we'll definitely invite you for the same. And we hope to see you all over there for sure. So with this, we end our session, and we really thank you for your time and also your patience, and also for sharing your most precious research work with us. And I hope everyone had a good time learning about the other researchers. And yeah, thank you one and all. Have a great day ahead.
Thank you. See you
Thank you.
later.
Thank you, Dr.
Thank you.
Hassan. Thank you.
Thank you.